You're back, Mr. Long. I'm just kidding. You know, it's your favorite EPO. All right, so today we're going to be talking about the pain assessment. So when we're talking about pain, we're talking about the OPQRST. This does go hand in hand with like the old cards thing that we learned yesterday. So when we're talking about OPQRST, of course, we're talking about onset, provocation, or palliation. Someone forgot to write that, Mr. Bryan. Quality, lesion, and radiation, severity, and time. So when we're talking about the onset, this is how we're brought on this set of problems. When you're talking about that, you're also this is mostly talking about pain, of course. There are 5 different sets of pain models that we're going to be using. The most common one is the nociceptive or the somatic pain. This is basically your like just normal like pain. So if I punch you in the face, ow, that's going to hurt. That's going to be your nociceptive. So the key thing here is that the neural pathways are still intact. There's really no nerve damage that's going on there. It's damage to the tissue, musculoskeletal system, or the viscera. It can be acute or chronic. So if you sprain your ankle, that'd be acute, and then it hurts, keeps hurting for long periods of time, becomes a chronic issue. The neural pathways are not intact. So this is like if you did have any nerve damage, so like you have a burn or like something like shingles where like it has damage to the nerves, but you're still feeling pain, that's going to be neuropathic. Related to lesions or disease affecting the somatosensory system, it can persist after initial injury, becoming burning, lancinating, or shock-like. Central sensitization is talking about, that's basically hypersensitivity, as it says there. This is the one where it's like you kind of like touch yourself and then like you just that little tap and you're gonna be going like screaming bloody murder. Neural pathways are not intact, so again there's nerve damage there. Psychogenic, this is talking more about like if you have any like psychosomatic problems happening with you. So if you have like depression or like something like that, or anxiety, personality, cultural norms, social support. So personality and cultural norms, that talks about you know, some people, some cultures, they don't really like show their emotions on their face. They kind of try to be stoic and kind of like play through the pain type deal. So you have to be aware of that. And idiopathic pain, this is just pain that like you have no idea where it's coming from. There's no like logical reason why you're in pain, but you just are. So with provocation, palliation, that's talking about what makes it feel worse, what makes it feel better, anything like that. The quality is, of course, that like tell me what it describe that pain to me. Is it a burning? Is it a sharp pain? What kind of pain is that? Region, radiation, where does it hurt, and is it traveling anywhere? So if you hurt your elbow, but then you also say, yeah, and then it still like radiates down to my wrist or up towards my shoulder, that's something that you want to be aware of. Severity, where you're going to be using this, there's 3 types of scales that we're using. The most common one used is the numerical scale, so just that out of 0 to 10, how bad's your pain, 10 being the worst of your life. The Wong-Baker faces, you're mostly going to use those with like children. And then of course the defense and veterans pain rating scale, that's another one that like has the faces on it. It's more about that, you're gonna see that all throughout the clinics that you're gonna be here. And also all this is going to be recorded in your inpatient records and outpatient records. So in the inpatient, it's gonna be on the medication administration record and the nursing notes, which is your SF 501, 510. And the outpatient records, it's just a chronological record care. That's going to be annotated in your SF 600, in the emergency treatment record SF 558, and your field or mass casualty DD 113 80. Moving on to patient assessments, we've got pre-hospital and we've got outpatient and /inpatient. So for the pre-hospital, we've got the medical assessment or the trauma assessment. So when we're talking about medical, we're talking anything like if you have a bee sting to if it's like you're having a stroke or a seizure or like a heart attack. Trauma is of course anything that's damaging to the musculoskeletal system. Mostly talking about like nociceptive pain there. When we're talking about, so for the pre-hospital setup, basically it's going to be the same for both of them. It's just when we're talking about medical assessments, you're focusing more on that medical side. There can be a trauma associated with it, but the main chief complaint is going to be that medical, the NOI. So we're of course going to conduct the scene size up. We're going to assess the situation. That's where you're going to do that Dawn BSI, scene size up is my scene say of how many patients do I have, Primary assessment, that's where we're going to be getting our ANO status. We're going to be checking our ABCs. We're going to be checking our mental status, patient priority. That's where all that's going to happen. Secondary assessment, this is where you're gonna get your your patient history. The in-depth patient exam, that's where you're gonna do your head-to-toe exam, looking for vitals, and also, of course, VCAP BTLS with that physical exam. Then you're also, at the very end, once you've checked everything, you're gonna look for non-life-threatening injuries. And then after you're done with all that, you're going to transport, and during that transport, you're gonna reassess, depending on if he's high priority or low priority, every 5 to 15 minutes. Your VIPS is your vitals, injury sustained, primary and secondary assessment, and then the MISS report is your motive mechanism / nature of illness. Your injury sustained, the signs and symptoms, and the treatments that you have administered. When we're talking about our inpatient, outpatient, that's basically just your SOAP, gather SOAP notes. Obviously, we talked about that yesterday. So your subjective is going to be your chief complaint. What is the main reason why we're being called or you're coming into us today? The history of illness. So we're talking about the old carts, just like we talked about over here with the OPQRST model. That's talking about like what is going on with you, whether it be pain or any other issues that you are having. Any past medical history, so like pertinent medical history, that's talking about not just the history of the illness, or it's just anything that might have to do with that type of thing. So in class today, we talked about having someone that had her contact stuck in her eye, and then we found out that she has astigmatism. It's her first time, wearing contacts, so that's something that we might need to know. Any family history, of course, we're talking about like only immediate family, so mom, dad, brother, sister, and grandparents. We don't really care about like aunts, uncles, cousins, anything of that nature. Surgical history is going back anything at least 10 years. Anything more than that was just icing on the cake. It's important to know, but not really that relevant to what's happening right now. Social history, of course, is whether you smoke, how much you smoke, whether you drink, how much you drink, that kind of stuff, and the review of the systems. So we're talking about those 11 systems that I can't remember off the top of my head right now, but that's okay. That's what we got books for. Objective is anything subjective. So this is all what my patient is telling me. The objective is everything that I can find out for myself. So vitals, you can't tell me what your heart rate is. I have to find that out for myself. The general assessment, you're going to be checking your ANO status, if they're well developed, well nourished, any distress, so anything that you can visibly see, if they're guarding, if they're grimacing, anything like that, and their gait is how are they walking? Are they limping? Are they kind of a weird like step? The assessment, this is anything that this is where your diagnosis is going to go. Any diagnosis that the doctor or whatever provider is above you is going to say, that's where that assessment is going to go. And then the plan is basically the prognosis. How are we going to go from here? It's you're going to educate your patient on what's going to be happening within the next few days or months or whatever happens. Any medications prescribed. The duty status. So are they going to be SIQ? Are they going to be bedridden? Are they full duty? Are they limited light duty? Any follow-up instructions, tests that you might need to go. So if they need to go get further MRI testing or X-rays or like blood draws, anything like that. And also the sort of test can also be kind of conjoined with referrals. And that's it. Good luck with everything, everybody. Love you. Have a good day.